It was a case of a man, I believe he's in his 40s, with history of congenital glaucoma. Um, and he had multiple surgeries as a child. He had a trabeculectomy and a tube to maintain his pressure, and over the years developed corneal decompensation. So he came in with corneal edema. He also has like Haab striae, which are breaks in Descemet's membrane. And it was an interesting case to think about surgically because the Haab striae protrude from the posterior surface of the cornea. So typically we'll do an endothelial keratoplasty, either a DMEC, or typically if there's glaucoma surgery, a DSEC, since there's a little less manipulation. And that has to adhere to the back surface of the cornea. But if there's protrusions, like in the case of the Haab striae, it's hard for that to adhere because it can't be directly juxtaposed. So in the surgical case, I actually was able to peel off the Haab striae, and he did very well with the DSEC. So we showed the surgical video, and then his vision improved from, I believe, count fingers to 20/80. I think it was interesting because, we don't talk too much about this surgical approach in congenital glaucoma to endothelial keratoplasty. Those patients are at risk for corneal decompensation over the years because first of all, their cornea is stretched a bit because of the history of the glaucoma. And then a lot of times they'll have other procedures which reduces their endothelial cell count. And then also the breaks in Haab striae can damage the endothelium. And so it poses a surgical challenge, and that's kind of what we wanted to address with the video. I actually wasn't sure exactly what approach I was going to take. I hadn't peeled the Haab striae before, and when I grabbed it, I wasn't sure what was going to happen there, but it actually peeled off pretty nicely. And then underneath was a very smooth layer of cornea. In any patient with a history of glaucoma and tubes and trabs, you worry about the graft adhering and the gas or air staying in the eye because there's multiple ways it can exit. I believe this patient also had a history of vitrectomy, so like the gas or air can go into the back of the eye. I like to use 20% SF6 gas because it stays around a bit longer. And it was lucky that the gas stayed in the front part of the eye. It was a younger patient, as I said, in his 40s, so he was able to position well, and the transplant adhered nicely. And the other surgical consideration is that, so they have what's called ophthalmist, or their eyes longer, and so their corneal diameter is bigger too. Like typically the corneal diameter is 11 to 12 millimeters, and I think his was like 14 or 15. And so another consideration is what to do with the graft. Like, should the graft be larger or should it be the typical size, which is about 8 millimeters? In his case, I decided to use an 8 millimeter graft because it covered the center part of the cornea, and that adhered well and has done the trick. So I thought that was interesting also. It was a pretty typical postoperative course. I mean, he had a lot of corneal edema before the surgery. Even by the end of the first week, he was seeing better. The first few days, because they're looking through a gas bubble, the vision's pretty poor, and you just want to make sure that the graft is adherent. But by a week, yeah, as I said, he was seeing better, and his pressure has been okay. That's the other postoperative concern, because both from the surgery, but also they're on higher doses of prednisolone or a steroid drop to help prevent rejection. Sometimes that could cause a higher pressure. But so far, fortunately, he's been okay. Yeah, I think traditionally people would jump to a penetrating keratoplasty in these cases because of concern about the graft adhering and glaucoma and other factors, and probably just the architecture of the cornea and the Haab striae. But I think it's just interesting that you can peel that off. You wouldn't want to remove the endothelium unless you had cornea, obviously there, otherwise they'll get corneal edema. But his astigmatism actually improved. Like the shape of his cornea is better. So Maybe it's something to consider for our patients with a lot of irregular astigmatism who have already like borderline cell counts, or like maybe we should be intervening a little bit earlier and not waiting until they have florid corneal edema if there's, a good chance of doing well. Yeah, I think just the idea that the hot striae can be peeled off, like that seemed novel. I hadn't seen that done before. Um, and the I think we have to keep a watch on our patients with congenital glaucoma. Like, I think knowing that, obviously the pressure control is paramount, but we should understand that these patients are at risk for corneal decompensation. And so if we're doing something surgically, we should be careful about the endothelium and our manipulations in the anterior chamber.